Hello, good evening to all. Today I would like to discuss regarding one type of diffuse interstitial lung disease, that is DILD, or diffuse pericamal lung disease, that is DPLD. This is now the newer term used for interstitial lung disease, and this type is idiopathic pulmonary fibrosis, and this is most common variety of idiopathic interstitial pneumonia, almost accounting for more than 30% of cases of all type of idiopathic interstitial pneumonia. As you know that this is a variety of diffuse interstitial lung disease, and interstitial lung disease previously defined as interstitial lung disease because at that time it was thought that the disease process and the pathology occurs inside the interstitium of the lung. But now it is found that not only interstitium, which is the site of pathology of interstitial lung disease, it is also alveoli, alveolar epithelium, capillary, perivascular tissue, and perilymphatic tissue. They are also involved in interstitial lung disease. So better term is other than interstitial lung disease, the better term is that we can use diffuse interstitial lung disease. So diffuse interstitial lung disease is now defined as heterogeneous group of disorder, and that is the characterized by varying pattern of inflammation and fibrosis involving alveoli, alveolar epithelium, capillary, perivascular tissue, and perilymphatic tissue inside the lung. And one type of diffuse interstitial lung disease is idiopathic pulmonary fibrosis. So this coming to the classification of diffuse parenchymal lung disease. Diffuse parenchymal lung disease is altogether classified into 4 different categories, and those are DPLD of known causes, idiopathic interstitial pneumonia, and granulomatous DPLD, and other form of DPLD, that is lymphangiomatosis or pulmonary Langerhans cell histiocytosis. So these are 4 categories of DPLD, and among them interstitial pneumonia, that is idiopathic interstitial pneumonia, is one variety, which is further classified into 2 variety, that is non-familial and familial. Most of the cases, that is more than 80% of the cases of idiopathic interstitial pneumonia, are non-familial, and familial is counting for only 2 to 20% of the cases. Idiopathic interstitial pneumonia is further classified into 3 categories, that is subcategories: chronic fibrosing, acute, subacute fibrosing, and smoking related. So duration of acute is defined as the first 7 days, that is days to weeks. Days to weeks is called as the acute phenomena, and subacute is categorized as weeks to months, and chronic is categorized as months to year. So chronic fibrosing variety of idiopathic interstitial pneumonia, that is IPF, consists of idiopathic pulmonary fibrosis. So now we come to diffuse parenchymal lung disease up to the idiopathic pulmonary fibrosis. So up till now, what we know that idiopathic pulmonary fibrosis is one variety of chronic fibrosing form of idiopathic interstitial pneumonia. So idiopathic pulmonary fibrosis is a variety of idiopathic interstitial pneumonia, which is a type of DPLD. Most of the time idiopathic pulmonary fibrosis is non-familial. only less than 5% of the idiopathic pulmonary fibrosis is familial. And usually idiopathic pulmonary fibrosis occurs at higher age, more than 50 years old. And this diagram here shows that the red one is showing the incidence of the idiopathic pulmonary fibrosis with the age, and we saw here that we see here that the idiopathic pulmonary fibrosis tends to occur more towards the higher age, that is more than 50 years of age. So idiopathic pulmonary fibrosis has an older age of distribution, usually occurring after 50 years of age. And this idiopathic pulmonary fibrosis is usually chronic disease occurring over months to years, and this classification according to duration of interstitial lung disease prior to diagnosis has been classified as acute, subacute, and chronic, as we already have discussed during the classification of TPLD. And idiopathic pulmonary fibrosis classified under the chronic fibrosing variety. And coming to definition of idiopathic pulmonary fibrosis, idiopathic pulmonary fibrosis is defined as a specific form of chronic progressive fibrosing interstitial pneumonia of unknown causes occurring primarily in older adult, limited to lungs, and associated with histopathological and or radiological pattern of usual interstitial pneumonia. So this definition of idiopathic pulmonary fibrosis, we have to consider that this idiopathic pulmonary fibrosis is limited to lungs. As we know that there are several causes of DPLD, that is diffuse parenchymal lung disease, which are associated with the extra pulmonary features. Like you can take example of sarcoidosis. So sarcoidosis also cause of diffuse parenchymal lung disease. Usually features are present in hilar region in central lung field, central lung zone, and usually involving the middle and upper lung zone, characterized by multiple nodular features in the HRCT. And this sarcoidosis is usually associated with the extrapulmonary feature associated with that is joint involvement or kidney involvement or other skin involvement, eye involvement, and even central CNS involvement. So this must be noted here that idiopathic pulmonary fibrosis is only limited to the lungs, and most of the features of idiopathic pulmonary fibrosis is only limited to the lungs. So this must be included in the definition. And another point of defining IPF is the exclusion of other form of interstitial pneumonia. So during the classification of DPLD, as we know that DPLD is classified into 4 categories, and one among them is idiopathic interstitial pneumonia. And interstitial pneumonia is also classified into familial and non-familial, and this is further classified to different categories. So all category other than IPF must be excluded. This is the meaning of definition, that idiopathic non-specific interstitial pneumonia, respiratory bronchiolitis interstitial lung disease, dyschemic interstitial pneumonia, cryptogenic organizing pneumonia, acute interstitial pneumonia, these are also a variety of idiopathic interstitial pneumonia. So these all type of pneumonia must be excluded from the definition, then only we can reach the diagnosis of idiopathic pulmonary fibrosis. So this is the definition of interstitial pneumonia. So idiopathic pulmonary fibrosis is defined as a specific form of chronic progressive disease. As you know that disease progresses from months to year, and this is fibrosing interstitial pneumonia because HRCT shows that there is massive fibrosis inside the basal and subpleural zone of the lungs, and histopathology also shows there is marked fibrosis, patchy fibrosis with honeycombing. So this is fibrosing interstitial pneumonia of unknown causes, occurring primarily in older, that is more than 50 years of age, limited to the lungs. There are no extrapulmonary signs and associated with histopathological and radiological pattern of usual interstitial pneumonia. So this is definition, and patient profile is that usually involve male, more than 50 years of age, and most of the time idiopathic pulmonary fibrosis is associated with cigarette smoking. So this is only risk factor. This is not the cause of idiopathic pulmonary fibrosis. Rather, this is linked risk factor. Usually, there are no causes of idiopathic pulmonary fibrosis, that is not known causes, but there are certain risk factor which trigger fibrosis in case of idiopathic pulmonary fibrosis. So one among them is cigarette smoking, and strongly associated with idiopathic pulmonary fibrosis, especially in those with a smoking history of more than 20 years back per year. Another point is environment pollutant associated with increased risks of IPF, that is exposure to metal, wood dust, farming, raising birds, hairdressing, stone cutting or polishing, or exposure to livestock, vegetables, animal dust, etc. Though there are lots of discussion that some forms of viral infection like herpes simplex viral and influenza virus, they are associated with the pathogenesis of idiopathic pulmonary fibrosis, but findings are not conclusive. So infection are thought to be linked with pathogenesis of IPF, but there are no evidence regarding that. Now coming to another risk factor, that is gastroesophageal reflux disease. The mechanism that patient with gastroesophageal reflux disease have repeated microaspiration, and that repeated microaspiration will cause repeated micro injury in the lung parenchyma and lung tissue, and finally that cause fibrosis. This is proposed mechanism, and the evidence is that Lung Society of Indian Lung Society, they proposed that they found that more than 90% of the patient with idiopathic pulmonary fibrosis, they are associated with GERD as well. So thought that one mechanism of idiopathic pulmonary fibrosis is that repeated microaspiration will cause repeated micro injury, that is chemical injury especially, and will evoke fibrosis inside the lung, and that finally lead to causation of idiopathic pulmonary fibrosis. And genetic factors are also. So there less than 5% of the idiopathic pulmonary fibrosis, they are familial, and they are linked with overproduction of mucin 5A, mucin 5B genes, or defect or mutation in TORT gene, that is a telomerase receptor reverse transferase genes, or that is mutation in C terminus, and another are mutation in C terminus of surfactant A gene or surfactant B genes. So these are the some evidence found regarding mutation in certain gene, regarding overproduction of mucin A and B, and that is linked with familial idiopathic pulmonary fibrosis. So regarding pathogenesis of IPF. So usually abnormal wound healing leading to uncontrolled fibrosis. So mechanism underlying IPR are not fully understood but are thought to be divided into three stages. That is initial epithelial injury, that is repeated over months and years. First point. Second is abnormal and incomplete wound healing. Third is progression of tissue damage and fibrotic lung changes. So these 3 points is thought to be linked with the pathogenesis of IPF. Usually IPF or usual interstitial pneumonia, there are lots of factors linked with this pathogenesis of the uh, interstitial pneumonia. The first, we know that there are lots of risk factor like environmental factor, smoking, GERD, infections, and genetic factors. They are linked with the IPF, and there are certain genetic mutation and genetic overexpression of certain factor like we can imagine things that expression things like expression of mucin gene 5A and 5B. So these are present in the terminal respiratory passages in bronchus or alveoli, and these are linked with the production of mucin. So there are lots of genes, mucin 5A, mucin 5B, mucin 5C, and one article published by the American Society of Thorax and Critical American Society of Thorax and Critical Care, Pulmonary and Critical Care Medicine. They have found that while comparing interstitial lung disease patient with interstitial lung disease associated with scleroderma or non-specific interstitial pneumonitis and idiopathic pulmonary fibrosis, and they have estimated the expression of mucin 5A and 5B in these three categories of patient. They found that in idiopathic pulmonary fibrosis, expression of mucin 5A and 5B is almost double to in comparison to the mucin 5A and 5B expression in other diffuse parenchymal lung disease that is linked with scleroderma and non-specific interstitial pneumonia. So what they found that there is significant difference in expression of mucin 5A and 5B in case of idiopathic pulmonary fibrosis, and almost double the amount that is expressed in the other form of diffuse parenchymal lung disease. So it is thought that overexpression of mucin 5B and 5A is also the factor which evoke the fibrosis in case of idiopathic pulmonary fibrosis, and underlying mechanism has been postulated that with the overexpression of mucin 5A and 5B, this leads to hypersecretion of mucin in the distal airway, which causes the stagnation and accumulation of excess and extra amount of mucin inside the distal airway, which blocks the mucociliary process, which blocks the mucin clearance and leads to accumulation and gradual accumulation of mucin inside the distal airway. And there are two things happens after accumulation of mucin. One is that these evoke infection, secondary infection in the distal airway and inflammatory process and fibrosis, and this also cause apoptosis of the epithelium there inside the distal airway, and which cause fibrosis. So mucin 5A and 5B is linked with pathogenesis of idiopathic pulmonary fibrosis in this way. And there are also other toll interacting protein So these tall interacting protein interact with the tall like receptor in the lungs, and what this cause that after interacting with the toll like receptor inside the lung, this toll interacting protein they evoke the inherent immune mechanism. They evoke the innate and adaptive immune response inside the our lungs tissue, and that innate and adaptive immune response they produce pro-fibrogenic factors like the tissue growth factor, platelet derived growth factor, vascular endothelial growth factor. So these are the pro-fibrotic mediator which are released by the interaction of toll like interacting protein with the toll receptors and cause the fibrosis and hence the idiopathic pulmonary fibrosis. So there are also surfactant like protein. So surfactant protein C, surfactant protein A, and surfactant protein B. These are the protein types of surfactant protein. As we know that surfactant is synthesized inside the type 2 cells, alveolar cells inside the alveolar epithelium. So there are two type of squamous variety of cells in lining the epithelium in alveoli, type 1 and type 2. So type 2 is associated with the synthesis and secretion of surfactant. So surfactant is synthesized usually inside ribosome of the cells, and before secreting surfactant inside the alveoli, there is processing, that activation of surfactant molecule, and activation of surfactant molecule required the linkage with C terminus. When C terminus is linked with surfactant A or surfactant C, then this become active, then this is secreted into the alveolar epithelium. What happened in patient of idiopathic pulmonary fibrosis, usually in familial case, there is mutation in the C terminus of the surfactant protein. So due to acquired mutation in the C terminus of surfactant C and surfactant A, this become dysfunctional, and this dysfunctional surfactant A and surfactant C is not secreted in alveoli, and this go on accumulating inside ribosome, and ribosome go into a stress. Ribosome become a stress with the accumulation of excess amount of dysfunctional surfactant C and surfactant A due to mutation of the C terminus of this surfactant molecule. So if ribosome goes into a stress, gradually the cells type 2 alveolar cells, they change their form. That they are converted into mesenchymal cell. When what I want to say that when C terminus suffers mutation, surfactant protein C and A become dysfunctional, accumulated inside surfactant alveolar epithelial cells type 2, and that cells due to a stressed ribosomal condition, because ribosome due to accumulation of surfactant dysfunctional surfactant C and A protein goes into a stress, and this stressed ribosome change epithelial cell into mesenchymal cell, and hence hence there is proliferation and accumulation of extra matrix, because mesenchymal cell, they are fibroblastic cells. So more and more formation of fibroblast from the epithelial cell there inside the lungs in a patient of idiopathic pulmonary fibrosis, and this is linked indirectly with the fibrosis and the pathogenesis of idiopathic pulmonary fibrosis. There are also TORT gene. And what is taught in this disease is telomere reverse transcriptase. So what we know that telomere are the part of chromosome which is present at the end of chromosome, and telomerase are the enzyme which cuts the telomere and decrease the length of the chromosomes during the replication phase. So what happened sometime there is mutation in the telomere gene, and due to mutation this become defective, and defective telomere reverse task. Due to defect in the telomere reverse transcriptase, there is apoptosis of the cells, and apoptosis of the cells cause death of the cell, and then this lead to activation of innate and adaptive immune response, inflammatory response, and that cause fibrosis inside the interstitium. So overall these are the MUCB genes, or tall interacting protein, expectant, surfactant C, and telomere reverse transcript. The defect in all these, or dysfunctional state of all these, responsible for pathogenesis of familial variety of idiopathic pulmonary fibrosis. So all these factors, along with the genetic factors, chemicals, autoimmune, virus, these all cause imbalance between fibrotic mediators and anti-fibrotic mediators. So fibrotic mediators they go up, and anti-fibrotic mediators they go down, and this leads to extracellular matrix turnover, proliferation, apoptosis, and leading to excessive extracellular matrix deposition and causing fibrosis. So there are two or three drugs two or three drugs they target this pathogenesis. Like recently 2015 ATS and ERS guideline, they have recommended use of porphenidone and nintedanib. These two drugs they have recommended for use for the reduction of fibrosis in case of idiopathic pulmonary fibrosis, and they target these fibrotic mediators here in the pathogenesis of the idiopathic pulmonary fibrosis. They reduce the production of platelet derived growth factor, vascular endothelial growth factors, and tissue growth factors. They reduce the fibroblastic growth factors, and hence they reduce the extracellular matrix deposition, and hence reduce the fibrosis. So their site of action is fibrotic mediators. They reduce the production of fibrotic mediators during this passages, this pathogenesis. So this porphenidone and nintedanib, these two drugs recommended by the 2015 ATS and ERS guideline. And also there are previously there are lots of drugs been tried, like prednisolone been tried previously. Lots of physician and pulmophysician they have preferably used prednisolone, thinking that there must be some inflammatory pathogenesis underlying the pathogenesis of idiopathic pulmonary fibrosis. But now it been proved that lots of study they proved that prednisolone doesn't have any morbidity and mortality benefit in case of idiopathic pulmonary fibrosis. And also they have tried ambrisentan, bosentan, or mositentan. These are the endothelin receptors. Previously it was thought that these factors, risk factors of the idiopathic pulmonary fibrosis, they cause production of endothelin by the endothelium inside the lungs, and this endothelin 1, especially 1A, they cause vasoconstriction inside the arterial bed of the arterial bed, and this vasoconstriction, they reduce the blood circulation and cause tissue injury, and finally tissue injury cause inflammatory process that will lead to extracellular matrix deposition, that is fibrosis. But now it been shown by multiple or different study that these endothelial receptor antagonists like bosentan or ambrisentan or mositantan, these drugs, they do not have any roles in reduction of fibrosis in case of idiopathic pulmonary fibrosis, because endothelin are not supposed to take part in the production of fibrosis in case of idiopathic pulmonary fibrosis. So these are all regarding the pathogenesis of usual interstitial pneumonia and idiopathic pulmonary fibrosis. So overall we can remember that MU5C-B genes, TOLIP, surfactant protein C, telomere reverse transferase, these are the genetic locus or genetic factors which is associated with pathogenesis of the familial variety of idiopathic pulmonary fibrosis. And other are the risk factor, that is environmental factors, smoking, GERD, these are associated with the acquired variety of the idiopathic pulmonary fibrosis, which is the most common variety. Coming to the clinical feature of the idiopathic pulmonary fibrosis. So idiopathic pulmonary fibrosis usually occurs after the 50 years of age and characterized by non-productive cough, slowly progressing dyspnea, and on clinical examination, particularly inspiratory velcro-like crackles usually present in bilateral basal zone, and lung function spirometry, we show restrictive pattern of the changes of pulmonary function test, usually characterized by decrease in, that is lower force vital capacity with normal or increased FEV1 by FVC ratio. And usually also there is a reduction in total lung capacity with digital clubbing clinically. So ATS and ERS shown that almost 25 to 50% of the patient of idiopathic pulmonary fibrosis they have clubbing. But here lower down, what lung India, they shown that they have shown that almost 50 to 70% of patient with IPF they have clubbing. So in our context, most of the patient, or almost more than 70% of patient with idiopathic pulmonary fibrosis they have clubbing. And in late phase, cyanosis, cor pulmonale, and edema can occur. So idiopathic pulmonary fibrosis is a severe restrictive lung disease which limits on daily activities. More than 90% of patients with IPF they have symptom of GERD. So that 2015 ATS and ERS guideline, they recommended use of antacid in patient of idiopathic pulmonary fibrosis for the prevention of fibrosis, for prevention of disease progression. So this is the things we have to remember in the clinical feature. And actually restrictive pattern evaluation by spirometry, the spirometric examination in idiopathic pulmonary fibrosis, there is decreased FVC and FEV1, but FEV1 by FVC ratio is normal to increased. FB loop usually give the witch's hat type of the curve, and DLCO is usually decreased total lung capacity, and residual volume is usually decreased. So now up to that we have non we come to know that regarding definition, classification, pathogenesis, clinical feature of the idiopathic pulmonary fibrosis. So how will we approach to diagnose and treat a case of idiopathic pulmonary fibrosis? And this is the chart taken from ATS and ERS guideline. So first on the basis of clinical features and clinical findings, signs and symptom and pulmonary function test, we suspect that patient may have idiopathic pulmonary fibrosis. So diagnosis is very important in case of idiopathic pulmonary fibrosis, because we know that idiopathic pulmonary fibrosis is fatal disease, and after from the time of diagnosis, patient will have only 3 to 4 years of survival time. So patient may die within this period, that is 3 to 4 years. This means that patient will only survive for 3 to 4 years after diagnosis. So diagnosis is important in case of suspected IPF. If you suspect IPF on the background of history, clinical evaluation and PFT. So history, that is clinical feature, clinical evaluation and PFT give us clue to suspect either patient is having IPF or not. So we must take detailed history regarding diffuse parenchymal lung disease, that is regarding patient may have sarcoidosis, patient may have vasculitis, patient may have urinary granulomatous, patient may have systemic lupus erythematosus, patient may have Sjogren syndrome, patient may have rheumatic lung disease, patient may have idiopathic pulmonary fibrosis as well. So we have to take detailed history to exclude all those causes other than idiopathic pulmonary fibrosis, that is diffuse parenchymal disease of non causes. So we must take detailed history to exclude the identifiable causes of ILD, that is interstitial lung disease, or DPLD, diffuse pulmonary lung disease. So take detailed history regarding all other identifiable causes and just exclude them all, and then come to if there are no any identifiable causes of ILD in this patient, and we suspect that symptoms are suggestive of IPF, then do HRCT. And HRCT is actually choice of radiological evaluation in patient if you are suspecting ILD or DPLD or even IPF. So on the background of HRCT finding, we can classify idiopathic pulmonary fibrosis as usual interstitial pneumonia, possible UIP, and features inconsistent with UIP. So what are the HRCT feature of usual interstitial pneumonia? Usually idiopathic pulmonary fibrosis, the basal and subpleural zone of the lung is involved. So there are reticular opacity, honeycombing, and usually reticular opacity and honeycomb is patchy. So patchy involvement of subpleural and basal zone of lung, usually basal zone of lung and subpleural zone of lung is having reticular opacity more than ground glass opacity, with honeycombing, with or without tractional bronchiectasis. This shows the patient is having usual interstitial pneumonia. So HRCT, if their involvement is basal zone, subpleural zone, and findings are reticular opacity with honeycombing and with or without tractional bronchiectasis, these are present, then this is a patient of idiopathic pulmonary fibrosis. If these all features are present, even lung biopsy or surgical lung biopsy is not needed. But if patient is having patchy involvement, patient is having basal and subpleural zone having reticular opacity, and if patient is not having honeycombing, then this is the possible UIP. But in those cases in HRCT, we must exclude other causes of the DPLD, like if there is bilateral diffuse lung involvement and there are ground glass opacity more than reticular opacity, there are nodular involvement, that is multiple nodules present inside the lung, if there is consolidation and lobar or segmental infiltrates in the HRCT. So if there are consolidation, there are segmental infiltrates, there are multiple nodular infiltrate inside the lungs, and markedly upper and middle lobe of the lungs are involved, and ground glass opacities are more than reticular opacity, definitely these are the not findings suggestive of idiopathic pulmonary fibrosis. So we must exclude those all other causes of idiopathic pulmonary fibrosis. And what we must know that the HRCT finding predominantly in case of idiopathic pulmonary fibrosis is reticular opacity, basal and subpleural involvement. This is the classical involvement or finding, HRCT finding of IPF. Ground glass opacity is not finding of IPF. Actually, ground glass opacity is common in other disease like interstitial pneumonia, other is even pulmonary hemorrhage, hypersensitivity pneumonitis, that is chronic hypersensitivity pneumonitis. So these are the dyschematic interstitial pneumonia. These are the cases where ground glass opacity is present. So hypersensitivity pneumonitis, dyschematic interstitial pneumonia, respiratory bronchiolitis, drug toxicity, and pulmonary hemorrhage, these are the disease condition which is characterized by ground glass attenuation. But ground glass attenuation or opacity is not the classical feature of IPF. Actually, reticular opacity is more in case of IPF than ground glass opacity. So if these ground glass opacity, lung consolidation, nodular infiltrate, or isolated lung cyst, or miliary lesions, or hilar lymphadenopathy, if these are present, then just exclude those causes because these are not feature of IPF. So these features must not be present there. If they are present, they are still present, and you are still suspecting that patient is having idiopathic pulmonary fibrosis. So this is not the logic behind the diagnosis of IPF. Just exclude those features. Now, if patient is having all the features suggestive of UIP, then this is IPF, no doubt. But if there is no honeycombing despite the subpleural and basal involvement of reticular opacity and patchy involvement is there, then go for surgical lung biopsy. What I mean to say that there are features of usual interstitial pneumonia, that is IPF. There are symptoms and signs suggestive of IPF, but some features, that is honeycombing, is not there. If honeycombing is not there, then to confirm diagnosis, go for surgical lung biopsy and see what is the histological features there. And what we know that histological features of IPF, that is classical IPF, is again that marked fibrosis, patchy involvement more towards the basal and subpleural zone and paraseptal zone, So biopsy targeting those regions, vessel zone, paraseptal zone, subpleural zone, will indicate will reveal marked fibrosis, patchy involvement with honeycombing. This is the first classical feature of classical histological feature of suggestive of IPF. Then second is that there are fibrotic foci. There are fibrotic foci within the lungs. That is that histology revealed fibrotic foci, and we must exclude other findings suggestive of disease condition other than idiopathic pulmonary fibrosis. So what are the other features suggestive which are not which must be excluded from the diagnosis of IPS? That if histology revealed highly membrane like features, or it revealed granulomatous condition, it revealed nodular condition. So these are not the features suggestive of idiopathic pulmonary fibrosis. These are suggestive of other conditions. So we must exclude those all findings, and only the finding which are more suggestive of IPF, they are patchy infiltrate, they are fibrotic foci, they are marked fibrosis, honeycombing, and these are the findings suggestive of IPF. If these findings are present, definitely this is a case of IPF. So in short, what I want to say that if we suspect a patient be a patient of IPF, just exclude other identifiable cause, then do HRCT. If HRCT findings are reticular opacity, honeycombing, patchy infiltrate, more present in the vessel and subpleural zone, this is a case of IPF. And surgical biopsy, if surgical biopsy reveal patchy infiltrate, fibrotic foci, marked fibrosis with honeycombing, this is a case of IPF. In short, and ground glass opacity is not feature of IPF, we have to know. So what is diagnostic criteria? Now just exclusion of other causes of the ILD, this is the first. Second is presence of usual interstitial pneumonia pattern on HRCT in a patient not subjected to surgical biopsy. And third criteria is a specific combination of HRCT and surgical lung biopsy pattern in a patient subjected to surgical lung biopsy. We already have discussed these all. Then HRCT finding also we have discussed. See, here is subpleural basal predominance, reticular abnormality, honeycombing with or without tractional bronchiectasis, absence of feature listed as inconsistent with UIP. And what are the feature listed inconsistent? See here, these are the upper and middle lung predominance. Now usually upper and middle lung predominance we see in the hypersensitivity pneumonitis and pneumoconiosis as well, silicosis, berylliosis or berylliosis, coal marrow pneumonia. These all have X-ray feature or HRCT feature most towards the upper and middle zone of the lungs. Even sarcoidosis, pulmonary histiocytosis, chronic hypersensitivity pneumonitis, chronic infectious disease like tuberculosis and histoplasmosis, they all tend to involve upper and middle zones of the lungs. So this must be excluded. Then peribronchovascular predominance, they are the cryptogenic bronchiolitis associated ILD, sarcoidosis, even the lymphangitic carcinoma, they all involve the bronchovascular region, that is central region of the lungs. Then extensive ground glass opacity, as we know that ground glass opacity is not feature of this IPF, that is idiopathic pulmonary fibrosis, ground glass opacity is the feature of hypersensitivity pneumonitis, dyschematic interstitial pneumonia, in certain case of pulmonary hemorrhage or drug toxicity or respiratory bronchiolitis associated ILD. So these are the conditions where ground glass opacity is important, and mostly in case of hypersensitivity pneumonitis, dyschematic pneumonitis and pulmonary hemorrhage. Classical there are glass opacity. Then profuse micronodules. So profuse micronodules is not feature of this IPF. We must exclude profuse micronodules if these are present in case of in HRCT. This is not a case of IPF. We should know. So if profuse micronodules are there, we should consider, we can consider sarcoidosis, vaginal granulomatosis, rheumatoid nodules, Sjogren syndrome, systemic lupus erythematosus, lymphomatoid granulomatosis. These are the classical, even a certain case of vasculitis. So sarcoidosis commonly, vasculitis, rheumatoid nodule, Sjogren syndrome, vaginal granulomatosis. These are the classical condition where multiple nodule bilaterally over the both lung, mostly in the upper and middle zone of the lung they are present. Must exclude these are. Then consolidation, obviously. So consolidation, these are more common in chronic eosinophilic pneumonia, bronchiolitis obliterans, organizing pneumonia. So these are the features of the HRCT feature inconsistent with UIP. So what is criteria that we must exclude all these features, all these findings before diagnosing idiopathic pulmonary fibrosis. So in short, we can see that here we can see some picture of the normal lungs and the picture of the patient with IPF. We can see here that this picture A, B, C, D, we can see that there are these are the section from the vessel zone, and we can see here that there are subpleural reticular opacity. We can see patchy involvement and subpleural involvement, and there are no ground glass opacity, and there are more reticular opacity and honeycombing and patchy involvement. So these are the cases of usual interstitial pneumonia. And tractional bronchiectasis, here we can see tractional bronchiectasis in the vessel zone, and this is the features of the consistent with possible usual interstitial pneumonia. And here lower down we can see that there are lobar involvement, there are lobar infiltrate, consolidation, ground glass opacity, diffuse over the upper and middle zone, more towards the, and central involvement, more central involvement, bilateral diffuse ground glass opacity, and these are not the feature of IPF. So we must exclude if there are diffuse bilateral involvement more towards the middle and upper zone, and there are consolidation, nodular opacity. These are the not feature of idiopathic pulmonary fibrosis. We must exclude them all. So till now we have known the histological features of the surgical biopsy of lung of a patient of idiopathic pulmonary fibrosis. So there are some other investigation which support the diagnosis of idiopathic pulmonary fibrosis, and one among them is bronchoalveolar lavage as well. As we know that classical feature, normal feature of bronchoalveolar lavage is consisting of more than 85% of the neutrophil. So bronchoalveolar lavage consists more than 85% of neutrophil, the macrophages, and less than 10% lymphocyte, less than 2% neutrophil, less than 1% eosinophil. But in case of idiopathic pulmonary fibrosis, here we can see that IPF have predominant neutrophil. So what is important that IPF is having 15 to 40% of neutrophil in bronchial lavage. So this is also supportive of diagnosis of IPF by bronchoalveolar lavage. If bronchoalveolar lavage analysis revealed 15 to 40% of neutrophil, and this is certainly supporting the diagnosis of IPF. Otherwise, lymphocytic predominance will deviate diagnosis towards the sarcoidosis, hypersensitivity pneumonitis, and eosinophilic bronchial lavage finding deviate diagnosis towards the eosinophilic pneumonia. And there are also CD4 and CD8 ratio. Usually normal bronchoalveolar lavage has CD4 and CD8 ratio less than 1.5. If it is less than 1.5 or less than 1, this is in case of hypersensitivity pneumonia, and more than 2, that is CD4 and CD8 ratio more than 2, this is in case of sarcoidosis, but this is not significant in case of IPF. So only neutrophil predominance is the feature of IPF, and IPF having neutrophil count in bronchoalveolar lavage up to 40%. So this is one feature which can support the diagnosis of IPF, and there are other live investigation which we have to do in any case of DPLD, and they are ANA, and usually 17 to 25% of the cases ANA is positive in case of IPF, but ANA can be positive in normal individual also up to 30%. So this must be considered. Otherwise we have to do for the evaluation, that is NT-CCP, RA factor, NT-SSA and NT-SSP for ruling out Sjogren syndrome or NT-topoisomerase, SCL70, which is very sensitive, more than 90% of 99% specific in case of scleroderma and associated DPLD, and raised MMP1 and MMP7. This is matrix metalloproteinase 1 and matrix metalloproteinase 7, and serum level of MMP1 and MMP7 is raised in case of IPF. So these are the lab investigation. Now coming to natural history of IPF. Now IPF is fatal disease, we know. From the diagnosis, patient have survival period of 3 to 4 years only. So some patient through the course of IPF can be stable. So only few number of patients are stable, going through the stable period for months to years, and most of them are slowly progressing. So IPF is slowly progressing in most of the cases and rapidly progressing in few cases and stable in few cases. But slow progressor and stable patient, they have frequent worsening, frequent exacerbation, usually infective exacerbation, and this is the cause of death in case of idiopathic pulmonary fibrosis. So this is the natural course or natural history of the IPF, and there are selected feature associated with increased risks of mortality in case of idiopathic pulmonary fibrosis, and we must evaluate patient thoroughly by different tests, by the HRCT or the echo or the 6-minute walk test or the spirometry. So we have to evaluate it regarding the level of dyspnea. If level of dyspnea is higher level, and DLCO is less than 40% of predicted. Desaturation is less than 88% during the 6-minute walk test, and extent of honeycombing on HRCT is increasing, and there is pulmonary hypertension. And longitudinal factor like increase in level of dyspnea, decrease in forced basal capacity by more than 10% of absolute value, and decrease in DLCO by more than 50% of absolute value, and worsening of fibrosis, that is recent worsening of fibrosis on HRCT is there. These are the predictor of the mortality in case of idiopathic pulmonary fibrosis. So we have to do these tests like spirometry and HRCT 3 or 6 monthly in case of idiopathic pulmonary fibrosis patient. Looks very expensive, but these are the predictor of the mortality in case of the pulmonary fibrosis, idiopathic pulmonary fibrosis. So what is it? Truth that some patient will die with IPF rather than from idiopathic pulmonary fibrosis. So almost 61% of patients they will die from idiopathic pulmonary fibrosis. Rest of the patient, almost 39 to 40% of the patient, they will die with IPF of other causes like ischemic heart disease. They account for almost 9% of death in case of IPF. Second is lung cancer. They account for almost 3% of death in case of idiopathic pulmonary fibrosis. Like congestive heart failure, they account for 1%. Cerebrovascular disease, they account for 1%, and pneumonia, they account for 2% of death in case of idiopathic pulmonary fibrosis, and 23% other causes. So almost 40% of the patient they will die with IPF of other causes like ischemic heart disease, lung cancer, pneumonia, congestive heart disease, cerebrovascular disease, and others. And 61% they will die with die of idiopathic pulmonary fibrosis. So what is important in this slide is that we must consider other comorbidities, and we try to control, we try to cure those all comorbidities in case of IPF, and certainly we can reduce the percentage of death in case of IPF by almost 23% to 40% by controlling or managing other comorbidity in case of IPF. So this is important. And what is regarding management, that there are supporting management that with oxygen, symptomatic management, and a specific management, that is by drugs. So now come to the management of idiopathic pulmonary fibrosis, and we know that patient with idiopathic pulmonary fibrosis have very shorter survival period, and from the time of diagnosis patient will only survive for 3 or 4 years. So diagnosis is important, and treatment is usually long transplant, and long transplant is the choice of treatment in case of idiopathic pulmonary fibrosis, but this is not available in Nepal. So 2011 guideline on management of IPF, they have a strong recommendation against the use of corticosteroid, colchicine, cyclosporin A, interferon gamma 1b, bosentan, etanercept. So what previously they thought that the pathogenesis of the idiopathic pulmonary fibrosis is inflammatory. So they use corticosteroid, colchicine, cyclosporin, interferon gamma, bosentan, interferon gamma to target the inflammation. And they also thought that endothelin A and causing vasoconstriction is also a pathogenesis factors in the pathogenesis of IPF. So they are using endothelin receptor antagonist like bosentan, ambrisentan, mositentan, like endothelin receptor antagonist they previously used, but 2011 guideline on management of IPF by ATS and ERS, they just have a strong recommendation against the use of these drugs. They have also weak against all the weak recommendation, but against the use of azathioprine, prednisolone, and N-acetylcysteine triple therapy or N-acetylcysteine monotherapy, use of anticoagulation. So they have a strong recommendation against the use of anti-inflammatory and endothelin receptor antagonists. They have a weak recommendation against the use of NAC, azathioprine, prednisolone combination, NAC, NAC, that is NAC monotherapy, anticoagulation. But they have a strong use recommendation of a strong use for the long-term oxygen and the pulmonary rehabilitation, and porphenidone. They have used recommendation against the use of porphenidone by the 2011 guideline of the ATS and ERS. But what is newer in case of 2015 guideline, that they have recommendation, that is condition recommended for the use of nintedanib and porphenidone and also antacid. So 2015 guideline, they have a recommendation with the use of nintedanib, porphenidone, and antacid. So these three are the drugs now being recommended by 2015 ATS and ERS guideline. Although they have also a strong recommendation against the use of warfarin, prednisolone, azathioprine, N-acetylcysteine, ambrisentan, and imatinib, and bosentan, macitentan, like endothelin receptor antagonist. They have a strong recommendation against the use of these drugs. So 2015 have a strong recommendation against the use of drugs which are strongly recommended against the use in case of 2011 guideline, but 2015 guideline recommended use of nintedanib and porphenidone along with antacid to target the GERD. So there are lots of trials undergone in the 2014. There are Panther trial, there are Ascent trial, there are Impulses trial. So Panther trial is regarding the use of N-acetylcysteine. What was thought previously, that N-acetylcysteine increase the glutathione level, and so that by the antioxidant mechanism this is decreasing the fibrosis. And the second is that N-acetylcysteine down-regulate lysyl oxidase, hence decreasing the collagen deposition and hence decreasing the fibrosis. These were the proposed mechanism of action of N-acetylcysteine. But what Panther 2012 trials revealed that there are lots of adverse effect with the use of N-acetylcysteine. So with the use of N-acetylcysteine, there are increased mortality, there are increased morbidity, there are increased hospital admission, there are increased death of the IPF patient with the use of N-acetylcysteine comparing to the placebo. So there is no benefit of using triple therapy and monotherapy with the N-acetyl cysteine. Triple therapy means use of N-acetyl cysteine along with prednisolone, azathioprine, and monotherapy means only using NAC. So both triple therapy and NAC therapy in the panther trial, they do not reveal any morbidity and mortality benefit. Rather, they are associated with increased mortality, increased hospital admission. So that according to this panther trial 2015 and 2011, they have strongly recommended against the use of the NAC, prednisolone, azathioprine, triple therapy, and NAC monotherapy and azathioprine monotherapy. This trial, Panther Adverse Effect 2014 trial, they have shown that there is no significant difference with respect to the preservation of FVC in patient with IPF with the use of NAC. And this chart graph, we can see that while comparing to placebo and N-acetyl cysteine, there is slightly more decline in case of N-acetyl cysteine in forced vital capacity in respect to the placebo. So there is no difference in the preservation of FVC. Rather, there is increase in decline in the FVC with the use of NAC. So we should not use NAC. NAC doesn't have any mortality and morbidity benefit. So this is the all regarding the Panther trial regarding the use of NAC in case of idiopathic pulmonary fibrosis. Then second trial is Ascent trial, and Ascent trial is regarding the porphenidone, and this is very important trial, and this is published in New England Journal on 2014, and this trial revealed that porphenidone is have certain or definite mortality and morbidity benefit, so that FDA has approved use of porphenidone in case of IPF. And possible mechanism of porphenidone is by reducing the production and synthesis of tissue growth factor, matrix metalloproteinase like factor, and decreasing the collagen synthesis. So porphenidone has antifibrotic mechanism, although eject mechanism is not known. So capacity trial 2011 regarding the use of porphenidone, what they revealed that with use of porphenidone, there is reduction in FVC over the months to year is lesser in comparison to placebo. So capacity trial 1, capacity trial 2, which is conducted around 2011, which revealed that decline in FVC with the use of porphenidone is lesser in comparison to FVC, and this is the good point, that is positive point regarding towards the use of porphenidone. And by the evidence of this trial, FDA have approved the use of porphenidone in case of idiopathic pulmonary fibrosis. And another trial is Ascent trial, which is published in 2014 in New England Journal, and this Ascent study design involving 555%, which and those all patients were followed up to 52 weeks and grouped into two groups, one with the oral porphenidone 2403 milligram daily and placebo. An endpoint was a change in FVC or death, and change in 6-minute walk distance, pulmonary function test, and dyspnea and death. These are the secondary endpoint. What this Ascent trial, they revealed that treatment with porphenidone for 52 weeks significantly reduced disease progression as measured by change in predicted FVC, change in 6-minute walk distance, and progression-free survival. So treatment with pirfenidone reduce all causes of mortality, and treatment emergent IPF related mortality in pooled analysis at week 52. And generally pirfenidone was safe and well tolerated. So finally, what we know from this trial that pirfenidone as compared to with placebo reduced disease progression in patient with IPF, and treatment is generally safe and acceptable side effect profile and was associated with fewer death. So FDA finally approved this pirfenidone by the 15th of October 2014 and indicated for the treatment of IPF. So 801 milligram 3 times daily with food is the recommendation of FDA in case of IPF. And initially dose is started with titration. Day 1 to 7 we have to give 1 capsule thrice daily, and day 8 to 14 we have to give 2 capsule thrice daily, and from the day 15 onward we have to give 3 capsule thrice daily, that is 801 milligram. The problem is that FDA approval is this, but in our country drugs transported from India with the name of Perfinex 200 milligram capsules. Accordingly we have to adjust dose. So consider temporary dose reduction if patient is having elevated liver enzymes, photosensitivity and rashes and gastrointestinal disorder, because Essence trials they revealed lots of side effect with the use of pirfenidone, but those are all tolerable side effect like nausea, rashes, dyspepsia, anorexia, GERD, weight loss, insomnia, dizziness, vomiting. These all are significantly increased in the pirfenidone group in comparison to the placebo. So we must consider this side effect while using pirfenidone, because these are the common side effects they have been seen in a patient using pirfenidone in by the Ascent trial. So if weight loss is there, so monitor weight loss and calorie intake can be increased in a patient taking under the patient taking pirfenidone or patient under the pirfenidone. If your transaminase level are raised, then we have to go for the monthly LFT testing for the first that is initial 6 months, and then every 3 months thereafter. So other consideration are the drug interaction, hepatic impairment, renal impairment, smoking. Usually smoking decreases exposure to pirfenidone, so instructs patient to stop smoking prior to treatment with pirfenidone. And then impulses trial regarding nantidanib. Actually nantidanib is the triple kinase inhibitor, and they reduce the production of platelet derived growth factor, fibroblastic growth factor 2 and vascular endothelial derived growth factor, and hence reduce the pulmonary fibrosis. And impulses trial of the nantidanib shown promise for the FVC endpoint, as in this diagram we see here that with the increasing dose of nantidanib there is lesser reduction in FVC, and this is the significant point regarding the nantidanib. And this is the proof why 2015 guideline, ATS and ERS guideline recommended the use of nantidanib in case of IPF. And this impulses trial is also published in New England Journal around 2014, and impulses 1 and impulses 2, which is consisting 1066% and having two group, nantidanib 300 mg daily and placebo. And these trials shows significant difference in favor of Nantidanib for the change from the baseline of the total SGRQ score in IMPULSIS 2, and Nantidanib had significant benefit in adjusted annual rate of change in FVC. Nantidanib reduced decline in FVC, which is consistent with slowing of disease progression. So this is a important study, that is IMPULSIS trials, important trials, and which recommend the use of Nantidanib for the reduced decline in FVC and reduction in progression of disease progression in case of IPF. So Nantidanib is recommended by FDA as well, and this is used in the dose of 150 milligram twice daily, and which can be reduced seeing elevated liver enzyme or GI gas side effect. Like this trial has shown that diarrhea and nausea, vomiting and diarrhea is more common with Nantidanib. So if elevated liver enzyme and GI side effect are there, so dose can be reduced accordingly. So finally, clinical trial 2014, they revealed that NAC did not show any efficacy by panther trial, porphenidone and nintedanib, that is by IMPULSIS trial, so efficacy in mild moderate idiopathic pulmonary fibrosis. So these are three trials which we come across here, that is panther, IMPULSIS, and capacity. These are all the trials which concludes that NAC has no benefit, and porphenidone and nintedanib have benefit, mortality and morbidity benefit. They reduce the disease progression. So 2015 guideline, they recommend the use of Nantidanib and porphenidone. So up to that, we come to conclusion that only 2 drugs or 3 drugs have been recommended by 2015 guideline, and they are porphenidone, Nantidanib and antacid. So second line of therapy in case of IPF is oxygen therapy, which we all know that even 2011 and 2015 guideline, they have a strong recommendation for use of oxygen therapy, because this is only therapy which is proved, which can save the life of patient with idiopathic pulmonary fibrosis, and we must maintain SpO2 above 89%. And the lung transplantation for IPF is the one treatment which is mostly recommended, but this is most difficult part, because the lung transplantation is not available in Nepal, and even if available, patient will not afford because so expensive. And there are timing for listing for lung transplantation, because what we know that if patient is diagnosed, that is patient is diagnosed with IPF, patient must undergo lung transplantation, because lifespan is only 2 to 3 years after diagnosis. So what we know that diagnosis of IPF is the indication of lung transplantation, because this is only life-saving measure in case of, because or not other treatment is going to prolong life. Even LTO2, that is domiciliary oxygen, will not prolong the life beyond 2 to 3 years. Patient anyway going to die within 2 to 3 years after diagnosis. So this is very fatal disease. But there are certain criteria. If there is 10% or greater drop in FVC during 6 months of follow-up, and 15% or greater drop of DLCO during 6 months of follow-up, desaturation to less than 88%, or distance less than 250 on 6-minute walk test, or more than 50-meter decline in 6-minute walk distance over 6-month period, or pulmonary hypertension, or hospitalization due to respiratory decline, pneumothorax, acute exacerbation. These are the favorable point for the lung transplantation. So in this situation, patient must undergo lung transplantation, which is very difficult. But other therapy which are been tried is stem cell therapy, proteolytic enzymes therapy, but still study are needed to support this therapy. So what we know now that in case of mild moderate disease, pirfenidone and nintedanib has been tried. So just use pirfenidone, nintedanib in case of mild and moderate disease. Assess for 6 to 12 months. If patient is stable, improving, and FBC decline is less than 10%, DLCO decline is less than 50%, continue treatment. But if patient is worsening, even if use of pirfenidone and nintedanib and oxygen and other supportive therapy, and decline in FVC is less than 10, more than 10%, and decline in DLCO is more than 50%, just assess patient, continue treatment, and counsel for lung transplantation. This is the only way. So finally we come to the end of this topic, IPF. And what we know that IPF is a type of diffuse interstitial lung disease, and this is a class of idiopathic interstitial pneumonia. This is fatal disease, accounting for almost 30% of all causes of idiopathic interstitial pneumonia. There are not known causes of idiopathic pulmonary fibrosis. There are lots of theory being proposed in the pathogenesis of idiopathic pulmonary fibrosis. They are the environmental factor, there are cigarette smoking, there are infectious causes, there are other genetic factors which are linked to the pathogenesis of idiopathic pulmonary fibrosis. And there are certain clinical criteria, clinical features, signs and symptom, and pulmonary function test suggesting of idiopathic pulmonary fibrosis we come across. And we have study regarding the findings of HRCT finding of the idiopathic pulmonary fibrosis, and this is most important. We must do HRCT in all patients suspected of suspected to be having idiopathic pulmonary fibrosis. And what we have to know that idiopathic pulmonary fibrosis have HRCT finding more towards the basal and subpleural zone, and consisting most of the time consisting of reticular finding, reticular opacity along with honeycombing, and the findings are patchy towards the vessel and subpleural zone. And these are the classical finding of the HRCT finding of idiopathic pulmonary fibrosis. And we must know that ground glass opacity is not the features of idiopathic pulmonary fibrosis. And one another thing what we know that almost 50 to 70% of the patient of the IPF they have clogging. So this is also important feature. And management is this is fatal disease, and what in our hand is that oxygen therapy is most important in our cases. And second, we can start pirfenidone, but we must consider some warning point that this may cause liver function test impairment. So we have to do LFT baseline and LFT every 3 monthly, and then consider other side effect like gastric irritative side effect. And we can counsel patient for lung transplantation, but not possible in our context. So this is all about idiopathic pulmonary fibrosis today. And from up to now you must be having some idea regarding the approach towards the diagnosis and treatment of IPF. So friend, this is all for today regarding idiopathic pulmonary fibrosis, a class of diffuse parenchymal lung disease. So thank you, bye.